students. Hello, students. This is Dr. Chen, and I'm a colorectal surgeon from the Department of Colorectal Surgery, Fujian Medical University Union Hospital. Today, I would like to share this presentation with you. I would like to introduce something about the management of the injured patient. And this is my email address. If you have any question, please send email to me. Thank you. And first of all, I would like to introduce something about my hospital, Union Hospital. This hospital has a very long history. The former hospital was established about 160 years ago. And now we have more than 2,500 beds, receive more than 2 million outpatients and more than 100,000 inpatients per year. And we performed more than 100,000 cases of operation every year. And this is the group photo of our department. And our department, colorectal surgery department, was established by Professor Deng Zhi in 1995. Our department is one of the largest colorectal cancer centers in China. We have more than 1,000. We perform more than 1,000 cases of colorectal cancer operations per year, and we have performed more than 8,000 cases of laparoscopic colorectal cancer case operation. I used to work as a volunteer surgeon in Botswana for 2 years, and I was the member of the 15th China medical team. I worked in the Princess Marina Hospital, Gaborone, Botswana. And this hospital is the largest referral hospital in Botswana, and it has about 530 inpatient beds. And this is our members of the China medical team. Our team was sent by Chinese government to provide medical aid for the Botswana people. This is the main entrance of the hospital. This is the administration building. This photo was taken in theater operation room. This hospital has to treat a lot of patients, and you can see that some patients don't have enough beds in the room. Actually, in Botswana, they just have limited resources, both in medical care provider and medical resources. So that's why our Chinese doctor was sent to Botswana to provide medical aid. Botswana, this is the location of Botswana. It is far from China, more than 11,000 kilometers from Fuzhou. Botswana is a very beautiful country. They have very beautiful animals, and my family also has ever visited Botswana. This is my wife and my son. And in this hospital, I met a lot of friends, my wonderful colleagues. And in Botswana, I met many good friends. This is the photos of my friends. And in Botswana, I also met some doctors from America. This old gentleman, he's Professor Fabry, and he's the head of the surgery department of the University of Botswana. He's a very good, very kind mentor to the young surgeon. And I also learned a lot from him. And this professor is Professor Rory. She's a friend of Professor Fabry, and she visited Botswana for a short term. And I met her in Princess Marina Hospital. In Botswana, I performed lots of operation. In 2 years, I performed more than 600 cases, including minor and major operation. But in Botswana, most operation was done with open procedure. You can see that the incision on the abdomen is very large. For laparoscopy, we can just only laparoscopy procedure available in Princess Marina Hospital was laparoscopic hysterectomy when I was there because of limited resources. And you can see that for this obese patient, laparoscopy procedure is good for them. If not, we will have to make a very large incision to remove the gallbladder. And nowadays, in the Western country, most of operation appendectomy was done with laparoscopy procedure. And this is one of the visiting doctor from America, Dr. Mike. And he said that when he was there, he joined one appendectomy with one of my medical officer, Dr. Teresa. And they performed one open appendectomy. And Mike worked as the first assistant, and Dr. Teresa was the operator of the operation. And Dr. Mike said that this was his first open appendectomy. So actually, also in my hospital, most operation was done in laparoscopy procedure. If you have opportunity to visit my hospital, I hope you can come to the operation room to watch the laparoscopy procedure. When I worked there, I had to deal with lots of trauma patients. And from here, you can see that these 3 patients they were all the stabbed abdomen. And I also had many patients because from a traffic accident. And so today I would like to share how to share the knowledge of the management of the trauma patient with you. With my previous experience. And this is the lady. She got a stab to the abdomen. Also, the iliac artery was also injured, and she experienced massive hemorrhage. For this lady, I make a colostoma, and this photo was taken after the closure of the stoma. And today, I would like to introduce the management of the injured patient from these 3 aspects. And first of all, I would like to introduce the preface of the injured patient. The injured patient, the injured patient, we also call them a trauma patient. As a disease, trauma is a major public health problem. In the United States, it's the leading cause of death among people among 1 to 14.5. For younger persons, trauma is responsible for more death than all other diseases combined, and resulting in the loss of working years than all other causes of death. Because of the injured patient, and the prevalence of injury in the elderly population is also significant in America. About 6% of the medical care patient admission has traumatic injury as their primary diagnosis. The presentation of alcohol is a significant contributor to trauma, and around 1/3 of all traffic deaths are alcohol related. And the trauma also causes a lot of financial. It's also a financial issue of the government. Actually, when I work in Botswana, many I also felt that many trauma patients were alcohol related, and you know that they had there's some payday every month. After payday, they got the money, and some of them will go to drink a lot of alcohol. After that, people may fight and injure each other. The trauma patient I got, most of them were drunk, and that's not good for the patient. So I hope you students to tell your friends and your patients to quit alcohol. According to some textbook, trauma deaths have been classically described as trimodal distribution, with the peaks that respond to the types and the intervention that will be the most effective in reducing mortality. The first peak it will be the main major brain and spinal cord trauma, and it will lead to immediate death. Prevention for this remains a major strategy to reduce this death. The second peak, the early deaths, those that occur within the first few hours of injury. They are mainly caused by internal hemorrhage, and most of these injured patients are treatable. The third peak, it is the late death. It consists of patients who die days or weeks after injury. Around 61% are caused by sepsis and multiple organ failure. As many as 30% of late deaths could be prevented by improved critical care. However, with the advancements in care and maturity of the trauma systems, this kind of classical trimodal concept no longer applies. The incidence of the late deaths have declined from 20% to 7% to 8% of all deaths, and early deaths have shifted towards the left, created by bimodal distribution. For the trauma patient, the pre-hospital care and the triage are very important. The recent information shows that well-trained paramedics can prepare patients for transport quickly and then perform life support procedures with high rate of patient survival. The primary survey attempt to identify and treat immediately life-threatening conditions. So for your students, I hope you should know how to find out the life-threatening conditions. The immediate measures and the scene of an accident is, for example, when you are called to see the injured patient, what kind of assessment would you like to make? Firstly, whether the patient is first on the battlefield, beside the road, or in the emergency ward, or in hospital. The basic principles of initial management are the same. So I'd like to introduce something about how to make initial management for a patient. So first of all, it's very important to find out is the victim breathing. If not, please provide some airway and establish back mask ventilations. If you don't have this kind of device, maybe you can try the mouth-to-mouth ventilation, but it may have some potential risk of disease. And you also need to make assessment: is there a pulse of heartbeat of the patient? If not, begin closed chest compression to provide a blood supply to the brain. And you also need to notice is there gross internal breathing. If so, elevate the pad if possible and apply enough external pressure to stop the bleeding. And if the external bleeding of the limb cannot be stopped, a tourniquet can be used by trained providers, healthcare providers. But you need to be careful. If you use the tourniquet for too long time, maybe you can cause a gangrene or the ischemia of the limbs. So I will tell something more in following lessons. And we also need to know is there any question of injury to spine? If so, protect the neck with a neck collar before moving the patient. If you don't have a proper neck collar, sometimes you can also use some shoes or some towels to secure the head to prevent a secondary injury to the spinal cord. Here you can see that this gentleman, his head was secured with two shoes. And we also need to screen obvious fractures to prevent a secondary injury to the nerve and vessels. For the evaluation of the trauma patient, we need to follow this sequence, which includes primary survey, resuscitation, secondary survey, and definitive management. In the primary survey, we need to follow the procedure of ABCDE. I will introduce these 5 aspects. ABCDE need to be made and recorded in a medical record for the trauma patient. So this ABCDE procedure are very important. So I hope you can master this. First of all, A, it is airway. Techniques that can be read to establish the patent airway by protecting the cervical spine, including the chin lift or jaw thrust. And orotracheal or nasotracheal tube can also be inserted to provide the patent airway for the patient. But we also need to prevent the secondary injury to the spine. Here we can see the ways to provide the patent airway for the patient. We can pull the tongue out, or we can lower the jaw and lift the patient's jaw. And we can also insert the nasotracheal tube or use some orotracheal tube. Here is the manual, the way to use your 2 hands to provide the patent airway for the patient. And if the patent airway can be provided by previous methods, we can try to make a surgical glycothyroidectomy. And this method is very important. And I think that maybe you have ever seen this method in some movie or video. And this method is easy to be performed. And the way to perform this is, first of all, we need to find the location of this glycothyroid membrane, and it's just above the cricoid cartilage. When you find this membrane, you can make a incision about on the skin of it. Then insert some candy to open this membrane. Then insert one tubing. And this is also this picture shows the location of this membrane. And we make a incision here. Then insert a tubing. If you don't have a proper device to make this cryothymidectomy, we can just use one needle, a large needle, for example 14G. Just insert this tube into the trachea to provide the airway for the patient. Second primary survey includes breathing, and it means to make a certain of the ventilation for the patient. For breathing, there are some immediately life-threatening conditions: good intention pneumonia, good intention pneumothorax, open pneumothorax, and frail chest, and massive hemothorax. Please keep in mind that chest injury is the second most common cause of the asphyxia. This photo shows how to relieve the pneumothorax. Tension pneumothorax must be immediately decompression by a needle introduced through the second anterior intercostal space. A chest tube is usually inserted in the mid-axillary line at the level of the nipple and is deducted posteriorly or superiorly towards the apex of the thorax. The tube is attached to a three-bottle suction device, and the rate of escape of air is indicated by the appearance of bubbles in the second of the third bottles. Cessation of bubbling suggests that the air leak has become sealed. This photo shows a flare chest. Because with the flare chest, the patient cannot breathe very well, and this condition need to be treated immediately. And the third important thing for primary surgery is circulation. It means that we need to give enough proper circulation for a patient. We need to make assessment: is there any hemorrhage? If patient have external hemorrhage, we can provide some local pressure and alleviate the part of bleeding, and we can give firm pressure on the major artery. When all other measures have failed, a tourniquet may be necessary to control major hemorrhage from extensive wound or major vessels in the limbs. But please keep in mind that we should need to loosen tourniquet at least every 20 minutes for 1 or 2 minutes. For the patient who don't have enough blood in their vessels, we need to give when you make a vascular access and make a resuscitation. A large intravenous catheter need to be inserted, and we need to begin with rapid crystalloid infusion. And we sometimes also need to give some blood product. And for the fourth part of primary surgery, it is to make assessment of disability, and it is also means that neurological assessment. The most common causes for the disability include alcoholic intoxication and some brain injury, diabetic acidosis, and other causes. And also it has some hypovolemic shock also can cause some neurologic disability. For this kind of patient, we need to know the further history of the patient and do some physical examination. And the laboratory tests and the head CT scans are also very important for the diagnosis. For physical examination, we need to make a GCS score. It is Glasgow Coma scale for the patient. This GCS score is very important, and we need to get the score of this patient from 3 aspects, including eye-opening response and verbal response and motor response. The highest score of this GCS scale it is 15. If the patient's GCS is less than 8, it will indicate a very severe injury to the patient. If GCS is 9 to 12, it indicates a moderate injury. But this score are most normal scores in recovery wards. If the GCS is higher than 13, it means that it's minor injuries, which are managed. This GCS assessment is very important. I hope you can master this. For the E of ABCDE, the final one is the exposure E. It means that all surfaces should be examined to identify injury that may not be rapidly apparent. After inspecting all surfaces, warm blankets and warm devices should be placed to avoid hypothermia in a seriously injured patient. And this is the chart of ABCDE. So for the primary survey, this is very important. I hope your students can master this. And for some more emergent patient, for example, the cardiac arrest patient, external cardiac compression may be very rarely successful. So for some patient, we have to perform emergency room thoracotomy, and it is very useful for the pericardial tamponade and penetrating thoracic trauma. And this is the way to perform the open cardiac massage. You need to use your 2 hands. You can use your 2 hands to perform this open cardiac massage. Don't use the tip of the finger. That will injure the muscle of the. When I work in Botswana, I used to perform 1 case of emergency room thoracotomy. This poor young man, he got one step to the heart, and he developed cardiac arrest. Then the cardiac arrest was due to the pericardial tamponade. So we performed the emergency room thoracotomy in the emergency room. And you can see that after the cardiac massage, the patient's heart beating was basically normal, around 98. But luckily, this patient died on the table. And after you make the assessment, if the patient got a shock, we need to do the resuscitation for the patient. For the trauma patient, we usually have 4 kinds of shock, including hypovolemic shock, cardiogenic shock, and cardiac compression shock, and the fourth one is neurogenic shock. And I would like to introduce something about these 4 kinds of shock for you. First of all, it is hypovolemic shock, and this shock is due to the loss of the whole blood or plasma. For a trauma patient, if the patient got a massive bleeding, the patient will be presented as a pale or bluish cold white skin, or a patient will have rapid bleeding, and also rapid and weak pulse. Because of the plasma brain is not enough, the patient will have altered conscious state, and the patient also will feel excessive thirst. And because of the blood supply to the GI system is not enough, the patient will feel nausea and vomiting. For this kind of patient, it's very important to give enough fluid for the patient. The second one, it is cardiac compressive shock. We also call it cardiac obstructive shock. Cardiac compressive shock is caused by compression to the thin wall of the heart, to the chambers of the heart, and by compression or distortion of the great veins entering the heart. And it may be caused by tension, pneumothorax, or massive pulmonary embolism, or by cardiac tamponade. The third one is the cardiogenic shock. It is caused by the decreased myocardial contraction, and is the most commonly caused by external injury or by myocardial infarction or arrhythmia. The third one is the neurogenic shock. It's due to the pooling of the blood in autonomically denervated small vessel, and it is usually due to the spinal cord injury. And other causes for reduced systemic vascular system may be caused by septic shock or anaphylactic shock. For the trauma patient, this kind of shock mainly caused by the injury to a spinal cord, and it makes a small vessel dilated, and it can cause relative hypervolume of the systemic circulation. And here, after the primary survey, we need to do a secondary survey of, and this kind of secondary survey will be the work of the specialist. But for the primary survey, it is the work of the junior doctor like you. After you become work as a medical officer or intern, you need to make a primary survey. But after that, after you reporting to your senior doctors, the senior doctor will come to make a secondary survey and make a definitive treatment for the patient. For secondary survey, a rapid and complete history and physical examination is very important. And for both primary and secondary survey, you need to make a written record of the finding. And for the injured patient, this kind of patient may have many doctors come to help him or her. But you get from the photo, you can see that there are many doctors there, but we need to have one doctor in charge. Basically, the surgeon usually is the captain of the team, and the surgeon need to make a decision what kind of examination need to be done, and when the patient need to get operated. So if you guys want to be a surgeon, you will become a leader of this kind of team. In the following contents, we are going to do some important injury of the injured patient, which include neck injuries and thoracic injury and abdominal injuries. For other injuries, other specialists will teach you. For example, for the head injury, the neurosurgeon we have their lesson in their chapter, and for the bone injury, the orthopedic surgeon they will teach you. Here I just make some brief introduction of these 3 kinds of injuries. For a neck injury, that is very important because our injury to the neck are potentially life-threatening because of the many vital structures. There are many vital structures in this area. You can see that there is big vessels in the neck that provide blood to the brain. And also here we can see that we have trachea and esophagus here. And from this photo, we can see there are many important structures here. For the neck injury, we usually divide the neck to 3 zooms, including zoom 1, zoom 2, and zoom 3. For zoom 1, it is the most caudal and encloses the base of the neck and thoracic inlet. It extends from the sternal notch to the clavicles to the cricoid cartilage. For the zoom 2, it is the mid neck, continues from the cricoid cartilage to the angle of the mandible. For the zoom 3, is upper neck, to enclose the region above the angle of the mandible up to the base of the skull. I hope you guys can master these divisions of neck zooms. Because in different zooms we have different structures. So different injured in a different zooms we are caused different injury to different structures. Here we can see that this is the injury to zoom 3, and this is the injury to zoom 1. In the neck injuries, we have different injury to different structures. We have different presentation. For injury to the larynx and trachea, it may be asymptomatic, but it also may cause hoarseness or other presentations. And for this kind of injury, it will be the work of the ENT surgeon. They can do a scope to check the larynx, and then you can see that there's some dislocation of the joint and some edema and some bleeding in this larynx. And in a neck injury, it also can cause an esophageal injury. Esophageal injury actually is rare because the esophagus is deep, but it may not present immediate symptoms. And also, the neck injury also can lead to cervical spine and cord injury. And the injury to the great vessels, it will cause massive hemorrhage, and usually it may follow by the penetrating trauma. For diagnosis, we need to know the injury of the history of injured patient, and we need to make a careful examination. And some X-ray or CT scan can provide some very important message for the patient. Here we can see that there's some air surrounding the esophagus, which means the preparation of esophagus. The complications of neck injury are related to the individual structure injury. It may result in acute airway obstruction or later tracheal stenosis or sepsis. For the treatment, it depends on the structure injured. For the injury to the vessel, some of them it can be repaired. It can be repaired directly, or it can be repaired with a graft. For some vessel injury, if it is not so important, we can just ligate. We just can ligate the vessel. For the venous injury, the best management should be for the venous injury, the vein can be ligated. Most of the vein can be ligated. And for the esophageal injury, it should be sutured and drained. And here from this photo, you can see that esophageal should be repaired by continuous suturing. The second part, I'd like to introduce some thoracic injury for you. Thoracic trauma accounts directly for and is the contributing factor in 15% of deaths due to trauma. Here we can see there are many different kinds of chest injury. It will lead to pulmonary failure or hemorrhage or cardiac failure. Early deaths of trauma of the thoracic injury are commonly due to airway obstruction or failure chest or open pneumothorax or massive pneumothorax or tension pneumothorax or cardiac tamponade. And late deaths are due to respiratory failure, sepsis, or unrecognized injury. Here we can see that there's some injury to the chest, and it leads to the rib fracture. This kind of rib fracture it can cause pain of the patient, and it can also cause pneumothorax or hemothorax. And this photo shows the flare chest. Flare chest, it means multiple rib fracture. Here we can see that there are multiple flare chest, multiple rib fracture, not just in one line. Equal two lines of ribs, which will result in it can cause it will lead to the stability of the chest will be compromised, and the patient will have difficulty breathing. For patients with flare chest, early rib fracture stabilization is important. It helps avoid the need of intubation and reduce the incidence of pneumonia. Here I hope you can keep in mind that this kind of flare chest not just include one line of rib fracture. Most of it have two lines, multiple rib fractures. For this kind of patient, we can do rib fracture stabilization. Use some special device. And in the chest injury, we also have some blunt tracheal bronchial injuries, and they often due to compression, due to compression of the airway between the sternum and the vertebral column in the decelerating steering wheel accident. Here are the different levels of bronchial injury. And previously we talked about the pneumothorax and hemopneumothorax. For hemothorax, it is the blood within the pleural cavity. It can be classified according to the amount of blood. If the blood is less than 350 milliliter, it is just a minimal hemothorax. If it's more than 300 and less than 350, but less than 1,500, it is moderate hemothorax. If the blood collection in the pleural space is more than 1,500 milliliter, it is a massive hemothorax. If the air is also present, the condition is called hemopneumothorax. For pneumothorax or hemothorax or hemopneumothorax, we can use the chest drainage system to drain the blood and the air. And it is a very important way to treat these three kinds of life-threatening conditions. Here's the main steps of chest tube insertion. Commonly, the chest tube is inserted at the middle axillary line between the fourth or fifth ribs on the line lateral to the nipple. Here we can see that we make an incision between the loops. And we use the cali to enlarge this incision and insert our finger into the pleural cavity and insert the chest tube into it. In a thoracic injury, we usually have a lung injury, which includes lung contusion. It will due to sudden concussion of the lung occurs after brain trauma or wounding with a high speed bullet. Most lung lacerations are caused by penetrating injury, and usually hemothorax is usually present. Here we can see this photo shows a gunshot injury. It not just cause a lung injury, but also cause destruction of the spinal cord. For the heart and pericardial injury, it usually occurs most often from compression of the steering wheel in a traffic accident. The injury varies from localized contusion to cardiac rupture. And for the esophagus, anatomically the esophagus is well protected, and preparation from external penetrating trauma is relatively infrequent. And there's one special injury in chest injury, it is like thoracic duct injury, which will lead to chylothorax or chylopericardium. It is a very rare complication of the chest trauma, but they are difficult to manage when they occur. Here, this photo shows the rupture of the thoracic duct. And if there is a chylothorax, the chyle will be collected in the pleural cavity. This is the chyle. You can see that it's milk-like. And this is the chylopericardium. There's free collection inside surrounding the heart. For the chest injury, we can also have a diaphragm injury. It is the wound of the diaphragm. This kind of injury must be overlooked because they rarely heal spontaneously, and because herniation of abdominal organs into the chest can occur with very difficult complication, either immediately or years after the injury. And this kind of injury need to be repaired with an unabsorbable suture. Usually we use unabsorbable suture to repair the diaphragm injury. And this patient is a step abdomen patient. He got one step to the lateral abdomen, but this kind of injury caused diaphragm rupture, and the colon just coming out of this incision. During operation, I reduce the colon and repair the diaphragm. And also you can see there's a chest tube was inserted in this in the chest. The third part of this content is abdominal injury. Abdominal injury is very common and very important, as we know that the abdomen has a very large area of the trunk, and it usually includes two kinds of trauma: penetrating trauma and branch trauma. For penetrating injury, may cause sepsis because it injure some hollow viscous, just like intestine, small intestine or large intestine. And penetrating injury usually cause severe nerve shock, usually involve a major vessel of the liver. For branch trauma, it is very important to use fast examination. It is using ultrasound to make assessment of the abdomen. And here, for the abdominal injury, first of all, we will have the abdominal wall injury. For this kind of injury, we need to debridement and irrigation and repair the abdominal wall. These two patients, they got the injury to the abdominal wall, and also a small bowel, also have small bowel injury. And here you can see that the small bowel just coming out of the incision. For liver injury, which will kind of difficult to manage, and but luckily most of the liver injury are low grade. The liver injury used to divide into 6 grades. For the grade 1 to grade 3, they are just low grade. For grade 4 to grade 6, it is very severe injury. And but for grade 6 injury, which was required as the hepatic avulsion, was removed during the last American Trauma Society grading revision because it is an unsurvivable injury. So presently we only have these 5 grades of liver injury. And luckily, most of our liver injury patients can be treated with a conservative management without operation. About 85% of patients with brown hepatic trauma are stable after resuscitation. So this CT scan shows different kinds of liver injury. So CT scan is very important for the assessment of the liver injury. In abdominal injury, we also can have some biliary tract injury. Injury to the gallbladder should be treated in most cases by cholecystectomy. And minor injury to the CBD, the common bile duct, can be treated by suture closure and insertion of a T-tube. For the major injury to the CBD, you will require jejunal stomy. Here, which means that we connect the CBD to the jejunum, and it is so-called jejunal stomy. And if there's some segmental loss of the CBD, it is best treated by this kind of jejunal stomy and drainage. This kind of operation is kind of difficult for me. I'm a general surgeon. I have never ever performed this operation. In my hospital, we ask HPT surgeon for help to perform this procedure. And in the abdominal injury, we usually use romet, the splenic injury. And the spleen is the most common injured organ in the causes of brown abdominal injury, because also we know that the spleen is very fragile. It's very fragile. It's easy to get ruptured. But currently, 50% to 80% of adults with brown splenic injury are treated with conservative methods. And we can also make some pancreatic injury during abdominal branch trauma. And the treatment for pancreatic injury depends on spleen and extent. The minor injury can just treat it with non-operative. But for major multi-injury injury, you need debridement and drainage. Most of the cases it doesn't need a very major operation. Here we can see that I also have 5 cases of liver injury from the ASD, and most of cases can be treated with conservative method or drainage. And as we know that in abdomen we have many large bowel and small bowel. For the GI tract injury, most of the injury can be just repaired. And but for the injury to the colon, sometimes we need to make some stoma. But most of it can be treated with primary repair. But for the rectum injury here, for some cases, proximal diversion is needed, which means we need to make a stoma in the proximal colon to make the feces diversion to prevent the feces coming down to the rectum, which may lead to the rectal leak, the leak of the repair side. And we also will meet some urological issue. The most common injured genital urinary tract organs are the male genitalium, the uterus, the urethra, the bladder, and and ureters or and the kidney. Here we can see that injury to the urethra, and this is the experience of the blood collection inside the scrotum. I would like to give you some take-home exams. Please describe the types of shocks caused by trauma, and please thinking about what is ABCDE procedure or primary survey for trauma patient. This ABCDE procedure are very important for primary survey. It will be important work for you after you become a resident or intern in your rotation in the hospital. So I hope you can master this. And I should these two contents I suggest reading. This book is very good for the management of abdominal trauma, and I like this book very much. It is a very great book for emergency abdominal surgery. I hope you can, if you have interest, you can send email to me and I can send some PDF copy to you. This book is kind of expensive actually, and you can also log on this website. You can scan this QR code to log on this website to see the approach to a trauma patient. And this MSD manual is also very good. I recommend this to reading to you. So, students, this is all the lessons I would like to share with you. Thank you for your attention. So, if you have any question, please send email to me without hesitation. I will ask your question as good as possible. Thank you.